There we go.
All right.
That's a good
Time.
speaker.
Yeah, we can turn it down if it's too much. Cool. Okay. Hello and welcome, everybody. We'll be hosting our healthcare roundtable today, and we'll sort of go around in circle, introduce everybody, tell a little bit about your work, why you're here tonight, and then we'll sort of break into a discussion, both about the work we've been talking about providing healthcare access to people in the food industry, and sort of what everyone brings to the table and how these plans and services can all work together. I'll start. My name is Noah Blador. I'm the director of the Dane County Food Collective. And if you're not aware, the Dane County Food Collective is a sort of very young and exciting new organization in Dane County. We started meeting a year ago, February 2022. It's a collective of chefs, farmers, community members who are passionate about food systems, just anyone who is interested in what's going on in the food community and ways to improve it. So over the last year, we've done a lot of work sort of centered around health and wellness and advocacy. Some of our main programs are wellness classes, which is trying to provide spaces for physical and mental well-being for people in the food industry. Currently, that's sort of taking place at Pat's Gym, and it's Mondays and Thursdays at 9 a.m., open to everybody. It's been a really fun space for people to participate and provide that sort of physical well-being aspect to people in the industry. In addition to that, we've done a lot of exciting work. We've worked with public health to distribute COVID tests, Narcan, fentanyl test strips, other things that sort of affect the food service industry, and providing those resources to our restaurants and other members. We've also started a program called Sunday Meets, which meets the first Sunday of every month. It's a space where people in the community can get together and just sort of talk about what's going on in their lives and what's going on in their workplace, and how that's affecting their mental health and just well-being. It's been a really great space, and just starting out, so it's something we really want to start promoting and getting out to the community a little more. We've done a lot of work related to how we can increase healthcare access to food service employees, and that's what tonight's discussion will be about. And then lastly, a new exciting program that we're really working on related to health and wellness is that we received some funding from the state to underwrite peer specialist certification for 18 members in the food service industry. So we're just trying to build that network out of mental health and addiction resources and specialists who can really provide some support to people working in the food service. So that's been really exciting. In addition to that, we're really focused on advocacy as well, trying to build policy and inform planning and legislation that reflects the needs of our local food system. So it's been really exciting. If we don't mind, we'll just go in a circle and I'll sort of move the camera around as we go through. Just say your name and why you're here and sort of what you're bringing to the discussion. Do you want to start?
Sure, I can start. I think I'm on the camera already. I'm Dr. Wendy Malaska. I'm a family practice physician with dedicated family care. I am one of the physicians that suffered what some people call burnout and what I like to call moral injury, and so left the healthcare systems to start my own direct primary care clinic. And now I am a much happier physician and I love what I do. So yeah, I'm here to help talk about healthcare access. The two big things I always talk about with direct primary care: access and affordability, because our current healthcare system is a little bit broken. So. But yeah.
Well, hello again, everyone. My name is Ingrid Ortiz. I am a registered nurse and a certified medical interpreter. I work with Dr. Wendy Malaska, and I'm here and happy to provide support to what you guys are bringing in. What an amazing job you're doing. Congratulations.
Thank you.
Hey, I am Murray Capel. I am a psychiatrist. I started having conversations about 5 years ago with folks in the food service industry about how to close the gap between those of us that want to provide care and those people that need care, because there seems to be the system gets in the way of that quite a bit. We started throwing around some ideas, and eventually after COVID, those conversations got wrapped up into the Dane County Food Collective. Luckily, there was a lot of energy bubbling up there, and some of our ideas actually started to be reality. So we'll talk some more about, maybe there'll be space to talk about mental health and addiction care. We may be talking more about primary care tonight, but we'll see.
You guys want to just introduce yourself?
Sure. I'm Melissa Bennett. I own Sweeternative Baking, and I'm here to learn more about healthcare for employees.
Great.
Hello, I am Brian Borkovic. I am with Destination Madison. So we're the Convention and Visitors Bureau for the Madison area, and so we support partners within the hospitality, tourism, food service space, and I'm interested in learning how Destination Madison can maybe be help facilitate some of these conversations, because it has come up in internal conversations as far as the workforce and the issues that the hospitality workforce has been facing, and I have no interest in recreating the wheel, and so we're very happy to figure out ways to partner, to join on current initiatives that are already happening. So very interested to hear about the wellness initiatives that you guys have going on.
Great, thank you. Let's flip around here.
Hi everybody, I'm Taylor. I am the owner and broker at Mindful Insurance Agency. So today I'm here to talk about and focus on individual health insurance needs for folks. So as a broker for individuals, I am actually free to work with. I get paid by the insurance companies. So if you have a plan on the marketplace or direct with an insurance company, I can help you navigate that confusing world. And yeah, so happy to be here.
Thank you.
Hello, Dan here with Avid Risk Solutions from Middleton. My main focus is supplemental benefits, so that's all the benefits that aren't related to health insurance, but still help you fund those large bills when it comes to medical insurance.
And I'm Katie Sells from Avid Risk Solutions. We're full service brokerage, but we're really focusing on the affordable options for employers. Healthcare costs continue to grow. Employer mandates and what they're required to do with these health plans are really strict. So we are looking for other avenues and affordable options to really help with attract, retain employees, but then also get the provided access to care, not keeping them within a certain system. So I'm here to go over individual health reimbursement accounts. That is a little aside from going to that strict medical group policy to offer your employees, but allow you to fund as an employer an account for your employees to use those dollars toward their individual premium. Also, they can use it for certain services, mental health, they can use it for wellness. So really finding it as a whole in those solutions rather than just the straight group policy.
Great.
And we're husband and wife for that.
Christy, do you mind introducing yourself?
Okay. I'm Christy McKenzie. I'm the owner of Pasture and Honey, and I'm just excited to host this event tonight where we can have a little bit more conversation about this. As a small business owner, I feel very stuck in between an expectation of what employers should be providing or should be able to provide, what we actually have budget to provide, and what really promotes wellness. And I feel like there's tension among those things. So I'm excited for conversation.
Great. Okay, so this will be a little informal to start, but Murray, would you mind introducing Wendy, or just how we want to start this discussion?
Yeah, sure. I think, and thanks for being flexible with the format. I think this would be valuable for folks for this to be a resource. This meeting is going to be recorded, because there's a lot of folks that are interested in this topic who maybe couldn't make it or didn't find out that it was happening, but really want to know this information and really want to know what the options are. So I think we'll be speaking to each other, but also kind of speaking to the future viewers. And I think Evan will be rolling in at any point. This sort of grew out of Evan's committee of one person that we had in our group. He was very passionate and is very passionate about finding healthcare solutions for his team, and did a lot of exploring. Could we pool together a bunch of restaurants and do some bargaining with HMOs and maybe get some sort of a rate? And after those discussions found like that was not actually possible, maybe illegal, I'm not sure, but like that wasn't going to happen. He was directed to Dr. Malaska eventually, and came back to our meeting saying, you guys gotta hear about this. And Dr. Malaska will talk about what she offers and what direct primary care is. I subsequently became a patient of Dr. Malaska's. I will break the doctor-patient confidentiality. I can do it. I get permission to do it. She is my doctor. And I will say, working within the healthcare system, I'm baffled by it. I can barely navigate it. I can't get into my doctor.
Wait,
I don't.
You can't?
Not my own doctor. My other doctor. It's terrible, and it is not healthcare at all. And Dr. Malaska's indirect primary care, I think, is something that I'm shouting from the rooftops whenever I get the chance. So I guess I would like you now to talk about direct primary care so people can hear about it. I find it's a topic that people often look like a dog going, what? And even the more they hear about it, like that really exists. But I will say that I'm so happy with actually being able to have healthcare as a doctor. So, Dr. Malaska, please.
Well, thank you. So, I think I'm going to start with, I'm very happy to have these three brokers here because they already get that our healthcare system is broken and doing things the same old way just doesn't work for employers, employees, individuals, etc. So thank you all for being here. My analogy that I use all the time is car insurance, and healthcare has gotten completely away, health insurance has gotten completely away from how we use car insurance, home insurance, any other type of insurance, is that we try and use health insurance for everything when it shouldn't only be used for those big disastrous claims. So for your car, you pay for the gas in your car, you pay for your oil change, you pay for your new tires, some windshield wiper fluid, and if your car's lucky, a wash here and there. That all comes out of your own pocket. That's primary care. So when you come in and you have an earache, or you want to talk about your blood pressure, or you have diabetes, or you need stitches in your finger, or an injection into your knee, that's all primary care. Preventative care as well, trying to keep people healthy and out of the hospitals, out of the ERs, out of the urgent care. That should be cheap, easy to access, and available when you need it. When you're in your big car collision and you need a bunch of body work or a brand new car, that's when your deductible kicks in, that's when your insurance kicks in. And so if you're in the hospital and you need a giant surgery or you need expensive chemotherapy drugs or whatever, that's when you should have some kind of backup health insurance, some kind of other supplemental care to cover that. But for the majority of stuff, I mean, primary care is not that complicated in terms of the care that I can provide, and because I've spent 20 years of my career mostly in rural areas where I don't have a lot of specialists, I can provide what I call womb to tomb care. So I do prenatal to hospice care and everything in between. And so what I see is that about 80 to 90% of your care can be done in my clinic. And so I talk a little bit about my story of how I ended up here because, yeah, I worked for 20 years in the system doing different things for a federally qualified healthcare center, for big systems, for rural clinics, for an inpatient hospice group. And I suffered enough of what some people call burnout, but I call again moral injury, that I finally had to leave the system. But the problem for me was that the only thing I've ever imagined myself doing was being a physician. This is since I was 5 years old, I was going to be a doctor. And so it got to the point where I was like, well, what am I going to do now? And so fortunately, my husband has experience with startup companies, and he's like, well, you just make a clinic. And I was like, what? But I had already been hearing about direct primary care in about 2019 when I was first leaving one of the systems. And then in 2020 was when I resigned finally from my job and said I'm out. And obviously this was during, it was in December of 2020, so this was during the pandemic. So having worked with COVID patients and done the whole, come home and get naked in the garage and don't let your kids hug you and stuff because we don't know what's going on. And then in 2021 opened my direct primary care clinic, and I could not be happier. Oh my God, I love what I do again, and it's exactly what I imagined in terms of being a full spectrum family practice staff. Having Ingrid is invaluable because now the patients that we serve a growing Latino population, we have an LGBTQ plus population, we have all of these different patient populations that, I'm like, I have more diversity in this one little clinic than I've ever had in any of my big clinics. And that just excites me because, on Monday we saw everything from somebody with multiple sclerosis, somebody who probably has a new diagnosis of lupus, cough and cold, baby with vomiting and diarrhea, everything. And that's, what we decided to do this for. I have a few slides that I was going to bring in just because some of them are kind of fun to look at. So this initial one basically shows, and everybody's kind of familiar with this, how the average contributions of employers and employees to kind of the healthcare coverage has changed over time. So forgive me, all you people here who need binoculars to see this, but in 1999, the employer contribution was about $4,200. The individual contribution per year was about $1,500 for a total of $5,700, 1999. This only goes up to 2017, and so we know it's only gotten worse since then. So total was $5,791. Total for just the family, $5,700. So we're now paying as the family what the total contribution was in 1999, which is insane. When you look at real hourly wages by workers, again, when we're looking at the very high wage earners, CEOs, et cetera, continue to make tons of money, but those in the middle and the lower wages, stagnant, because all of your contributions are going to your employer-sponsored healthcare, which gets taken out of your paycheck. You don't see that premium every month. You don't even realize it's there, but you're paying more and more. And then when you look at household spending, the only thing we're actually spending more on over time is healthcare. Everything else, when you look at it based on inflation and over time, we're actually spending less on. So food has gotten cheaper over time, clothing has gotten cheaper, houses have gotten cheaper, but healthcare has not. DPC. Direct primary care is completely different than having healthcare insurance. And like I said, because I don't deal with the health insurance anymore, it's awesome, it's wonderful, I love it. So basically what we do is we charge a membership fee monthly to our members, and we either do this to individuals, to families, or to employers. And I'll talk a little bit more about employers at some point here, but basically for that set fee, you basically get all of your care covered with me. So basically, it's a subscription model for primary care. It's your Netflix for primary care. So in February, I use a lot of Netflix, and in June, I don't because I'm outside. So some months you use me a lot, some months you don't. You end up paying the same amount per month, which hopefully then averages out over time. But that cost tends to be a lot less than what you would usually pay, and it covers everything. So there's no co-pays, there's no co-insurance, there's no deductible. So when you come in this week for your earache, it's covered by that same monthly fee. When you come in next week, because we were concerned your blood pressure was high at that earache visit, it's still covered by that same monthly fee. When you come in for stitches the next weekend, because that Easter ham got a little out of control, it's still covered by that same fee. So basically, there's no co-pays, deductibles, no hidden fees on top of that. And so therefore, we can easily say, you know what, this is what it's going to cost you per month. And then kind of like I said on here, you know, the thing that you need though is I still don't tell people, you know, hey, this covers you for everything. You still need some kind of coverage in case you need your gallbladder taken out, you need your appendix taken out, you need chemotherapy drugs, because you don't want me to take out your gallbladder in my office. So let's see here. What else can I tell you? Transparent pricing. Oh my gosh, this is huge. So one of the things that I hated as a doctor in the systems was that you could come to me with Blue Cross Blue Shield and you could come to me with Blue Cross Blue Shield, and your policies are completely different. And so when you ask me what the cost of your labs are, I have no idea, because I don't know what your copays and deductibles and coinsurance and so forth are, and what the negotiated price with the Blue Cross is with this health system and blah, blah, blah. So I don't know, can't tell you. Now I can tell you exactly. So for your complete metabolic profile, which looks at your blood sugar, your electrolytes, your kidney function, your liver function, it is $3.85 at my clinic. That goes to Quest Labs, which is a nationally known lab. And that includes my 10% markup for my tubes and supplies and stuff. So I made the mistake of telling a patient, that his cholesterol testing was going to be 682, and he was like, "Oh, okay, yeah, I guess let's do it. I have to do it anyway." And I was like, "Oh no, I don't think you understand. $6.82, because we're also used to paying hundreds of dollars for these labs, and you're like, yeah, $6.82, that can't be right." So yeah, basically transparent pricing. There are added costs on top of the monthly membership fee in terms of labs, generic meds that I dispense from the office, if we do radiology and things like that. But again, I know those prices up front, so you don't end up with a surprise bill down the road. Let's see here. So this is kind of pricing for individuals. Employer rates are pretty standard in terms of $70 per employee, and then employers are fun because especially smaller employees can decide. Smaller employers can decide what they do. So, like you were saying, Katie, some of the big employers over 50, you have to meet certain ERISA things and all these other kind of things. But the smaller employers get to do what they want, kind of. And so, if they pick something like this, they can say, so I have one employer group that is paying for everything for their members. So they pay for their entire membership fee, they pay for their partner's membership fee, they pay for the kids' membership fees, they pay for the meds, the labs, anything I bill through the clinic, they will pay for. I have another group that pays for all of the membership fees for, again, the employee, their partner, their kids, but they don't pay for labs or meds or radiology or any of that stuff. That's what the individuals that pay for. And then I have another group who has it set up where they pay half the membership fee for just their employees. But their employees can then add on their family and pay for that on their own as well. So there's a bunch of different ways to set this up, a bunch of different possibilities for that. And then, yeah, like we were talking about, laboratory prices, generic prices. Can I throw you under the bus one more time? Okay. One of my favorite stories with Ingrid when she was first starting to work with me and interpret for me was we had a Latino patient in, my Spanish isn't so good yet, so she was helping me interpret, and as the example on here shows, a 90-day supply of amlodipine, which is a common blood pressure medication, is $1.12. And so we're telling the patient, hey, I can get you this prescription. You don't even have to go to the pharmacy. We'll just get it out of my pharmacy in the back. Here you go, 90 days, $1.12. She's like, what? I'm like, $1.12. What?
Write it down.
$1.12. $12 cents? And so this is my favorite game I play with her is that, this morning, again, we had a patient in who needed a muscle relaxer. We gave him 10 days worth of a muscle relaxer, and it was 66 cents. And so he's like, okay, I guess I'm going to need to take out a loan and pay for that 66 cents. Healthcare just shouldn't be this expensive. And part of this I talk from my own experiences as a patient as well as a physician is that when I went to get my breast MRI done because I had breast cancer through one of the big systems, the estimated initial cost was going to be $6,500. And I'm like, I only have one breast left. Can I get half off? Like, no. I'm like, okay, fine. With my copays and deductibles and coinsurance, it was going to be like $3,200, so about half of that or something. I work with an independent radiology group. I had to drive to Milwaukee to get this done, but I had my same breast MRI done on the same 1.5 Tesla magnet with the same gadolinium injection for $650 cash. So I saved myself, I'm not even gonna do the math, but thousands of dollars to get this done in cash. Drove to Milwaukee, but it's an hour away. It was totally worth my time to go there and do that. And that's what the other thing that we provide as direct primary care is that knowing that there are certain independent radiology groups, independent specialists where you can go and do cascade prices, where a lot of times if you have that high deductible plan, you're not even tapping into that deductible because you're like, yeah, I'm not going to pay that $3,200 toward that deductible. I'm just going to pay $650 and save myself a bunch of money. So, let's see here. Oh yeah, so this is some of that pricing I was talking about. So, independent cascade pricing, colonoscopy, I can actually get you better rates if you're willing to drive to Chicago. So you can pay cash for about $850 for that. But if you look at the system, you can see where, this is $1,000. The super awesome thing is that one of the independent radiology groups that I work with in Milwaukee, because myself and like Dr. Amanda Primusberger, who has Roots MD, who's another DPC in town, and Dr. Eric Felipe, and a couple of us on independents have been talking with them. They are actually going to open an independent radiology group here in the Middleton area.
Sorry. You just mentioned the friend that I was going to refer to this sort of thing.
Oh.
Anyway, that's interesting. Yeah.
So they're going to actually open an independent radiology group in Middleton, which will be great because then our patients don't have to drive to Milwaukee to get some of these CTs and MRIs and stuff.
Do you know when that's opening?
May.
Oh.
Yeah, they're waiting on
something.
something. I can't remember what they were waiting on, but May.
Ooh, that's awesome.
So MH Imaging. If you need a contact, let me know. Christina Whippenforth is wonderful. All right. Oh, and then this is the other fun thing. Doctor-patient relationship. Oh my God. So that's the thing. And that's what I went into medicine for. And that's what I went into family medicine for, was to have that, be able to take care of the whole family and know that, mom's stressed out because she just had a new baby and we put grandma in the nursing home and, whatever else is going on. But to be able to have time with patients. And so working in the system where I kept hearing from my patients, Doc, it takes 3 months to get an appointment with you and then you only got 15 minutes. That's not the kind of medicine I want to practice. And so all of my office visits are scheduled for either 30 or 60 minutes. Doesn't mean you need to be there for that long. So if you're complaining of an earache and you just want me to check your ear, you're gone in 5 minutes, that's fine. But yeah, 30 to 60 minutes. So instead of saying, well, I have one more thing, and your doctor being like, nope, we already talked about the one thing, and you can't talk about 2 things at a visit because then I can't code bill it and get paid for it. You can talk about it, everything you want, and we get to sit down and talk a lot more about lifestyle issues and stuff like that. What is for pre-diabetic, what does your diet look like? Well, I'm a traveling salesperson, and so I eat in my car, and I'm like, okay, how do we work on that? Because we have to work within your lifestyle, but how can we make that better? So a couple different things like that. And then basically communication, and this is the other fun thing. So if y'all haven't heard, Meritor is starting to charge for MyChart messages. So any MyChart message that your doctor has to address in some particular way, you get charged for. So not only do you have that facility fee for walking through the door, or the telehealth fee for signing on to telehealth, you also get a MyChart fee for sending a MyChart message. I get to do, like I said, 30 and 60 minute visits. There's no facility fee. Parking is really easy at our clinic. There's no parking ramp fees or anything. And then you get my text, you get my cell phone and Ingrid's cell phone. So you can bother either one of us. You can text us, you can call us, you can email us, and there's no extra charges. I can do in-person visit, telehealth visit. I've done a few home visits. That does have a little extra charge just because of time and stuff like that it takes. But we offer all of these services and you don't get charged any extra for them. And so, yeah, you have a quick question on what's the dose of Tylenol for my kid and it's 8 o'clock on a Friday night? Just text me and I get back to you and it's easy rather than, waiting on a nurse line or Googling it or whatever. So I think it's a lot better. I like the follow-up that we're able to provide. Ingrid and I put a lot of tasks into our electronic medical record to remind us, hey, follow up with so-and-so in 2 weeks, see what their blood pressures are. Follow up with this person on this, so that we can kind of keep track of those things. So that's one of the things we like to do. Yeah, decreased ER urgent care visits, that's another big thing. So yeah, if you, like I said, if you've got your finger on a Saturday, give me a call. I'll meet you at the clinic and put in stitches. One day last summer, I was at the pool with my kids, which is about a mile down the road. They had their swim lesson, did a patient call that needed stitches, and so I went from the pool to the office, which is a mile away, and put in stitches, and I just put my white coat over my swimsuit, and I called it good. There you go. Yeah. But again, when you have this relationship with your doctor, you know, and you know that she's, and I told him I'm coming from the pool, you know, it paints me as a human and stuff as well. This was I talk about with my patients and stuff too. I'm a mom, I'm a wife, I'm president of the Wisconsin Medical Society right now, so I have other things going on in my life, which my patients really truly understand as well, and that, you know, they're not calling me at 11 o'clock at night for a refill of a prescription that can wait until the morning. But when they do need something, they know that they can reach out to me and I'm going to be there for them. So we try and do things like try and decrease specialist visits. We work with an online specialty group where I can refer patients. So like this new patient that we had today where I would think she has diagnosis of lupus. I get all these weird lab results and I'm like, I don't know, it looks like it, but I don't know. So I send it off to this specialist online, send all the lab results, clinical exam, and usually within 24 hours they get back to me and say, I don't think this is lupus, I think it's dermatomyositis, and can you add these labs and so forth. And so sometimes we can actually save patients visits to specialists, which is really pretty cool. Sometimes we need to go in to see specialists, and that's also interesting to me because now that I'm out of the system, the interesting thing is that I have to be old school, so I can't just send a referral in through Epic because I don't use Epic. So I have to call somebody, and when you actually apparently pick up a phone and talk to people, they tend to get your patients in pretty quickly. So instead of having, I had one of my colleagues who's in one of the big systems say, I've been trying to get this patient in for 6 weeks to see a surgeon for their hernia, and I'm like, I called it last week and my patient was already seen for his hernia. So I don't know if it's because I'm an independent outside provider that they're trying to get, extra business in, or because I'm old school and picking up the phone. But one of the things I like is, being able to navigate because, like you were saying, Dr. Kapal as well, is like, I've been a patient, I've been a doctor, I know the health system as well as I can at this point, but it's confusing. And I can't imagine, some of the, bills that I still get, and I'm like, you've got to be kidding me. You can't, no, And my husband's like, oh, let's pay it. I'm like, no, you can't pay that because this is not correct on here. But how do you do that as a layperson, as a normal person navigating the system? You just can't. And how do you navigate, potentially multiple specialists if you have something significant going on? So we try to act as kind of the quarterback or the conductor of your healthcare as well, and try and navigate some of that stuff for you. Not going to say that I completely understand your insurance bill if we do have to use insurance, but we can try and help with some of that. So, let's see here. Get care as often as I need it. So yeah, basically, one of the things I find is a lot of times too with new patients that I bring on, we spend a lot more time over the first several months getting people kind of tucked in, and then once people realize that you can't reach out to me at any point in time, they tend not to necessarily see me as much, but we can stay better on top of, and Ingrid does a great job of this, keeping track of preventative care and all of this kind of stuff, follow up with people. So, dedicated family, email, virtual communication, blah, 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 yes. And the last one too, this was fun in the system, was that every year, every employer is trying to negotiate new health insurance, get lower costs, etc. So this year your employer negotiates and gets quotes. So now you're seeing at UW. Next year they negotiate and get needs. So now you got to switch all your care to B. So every year I've seen patients switching back and forth, and that's a sure recipe for missing things, for things getting dropped, for not getting everything done, just switching back and forth. And so the fun thing with DPC is even if you change employers, you can still keep you. So even if you get your DPC through your employer, if you go somewhere else, now you just pay me as an individual, and you can still keep me as your doc. The cabin crazy expensive.
Yeah, right.
What's a COBRA? I don't know these things anymore. Yeah, exactly. So, and then Health Rosetta brokers are great. Our brokers here are lovely because they already have this But yeah, having some kind of other plan to back you up, I think, is kind of the important part that they can speak to a little bit more and stuff. So that, yeah, I'm not going to take the gallbladder out. I'm not going to prescribe the chemotherapy drugs. I'm going to hopefully catch your breast cancer before it becomes a big issue. But when you need that surgery, when you need that specialist and stuff, you're going to want something to cover you because that's where your big expenses are going to be. But for me, yeah, $1.12. Yes, and that's
barriers.
yes.
You
You
know?
want to speak to that a little bit? So,
Sure.
brought me my map and all of the stuff.
Yeah, breaking barriers. So for Christmas, I didn't know what to get Dr. Alaska. So I see her passion, and that kind of drives me and my energy to keep providing. And that's when we went into healthcare, right? To provide holistic care. I've got a map of the world. And now for our patients that are coming from all over the world, from all over the world, they're putting things. And so it's so beautiful to see people from Asia and Russia and Australia and Latin America, and the ability to provide that holistic care, and they break as many barriers: language, culture, mental health. It's just so, we're full, feel fulfilled as healthcare providers. So that's another very important aspect of healthcare, providing appropriate cultural care. So.
And I think that's one of the big things is like ever since I went into, again, family medicine, was that my residency was in an underserved inner city area. And then I went out to rural Colorado and worked for a federally qualified healthcare center. So with a large Latino and undocumented population at that point. And so my goal has always been to focus on some of our, what I would consider underserved populations. And I see that a lot in the healthcare industry. Or in the restaurant and hospitality industry, is because restaurants are expensive to run and they're small businesses, and how do we provide all of these benefits? And yet our staff makes too much to qualify for something like Badger Care, so then what are these people going to do? And so being able to provide a low cost option where you can get really good care, and hopefully, like Ingrid said, the best compliments I get are, my LGBTQ plus, patients saying, oh my God, I feel so comfortable coming here, or our Latino population, referring their family and friends to us, all of these different things. And so, being able to provide all of that and be that, kind of home clinic for people, I think is awesome.
Thank you.
Great, that's awesome. Thank you for sharing. Do you have a natural transition into what we'll talk about next? But I know before this we sort of talked about how health insurance fits in, and maybe we can give some of the brokers a chance to talk. Does that sound good?
You just did it.
Okay,
Cool. Thank you.
I can do a quick segue because so. And if you want to maybe position it
Yes.
as the brokers more, or not just me, but I, as we were having these conversations, I was really interested in bringing Dan and Katie in, because in what you described is exactly right. Like in restaurants and many other small businesses, the margins are so small that we're just not able to do a full employer-supported healthcare program unless we kind of cobble it together. So over the last 5 years, we've worked with Dan to integrate supplemental benefits, and working with Katie to monitor, okay, what does access to an employer-driven health plan look like? And we recently did a comparison, and I looked at the numbers, and they're completely inaccessible. But the things that are accessible are providing dental, vision, short-term disability, some of the other supplemental kind of wraparound insurances, and then recently you found out about ICHRAs as a potential, a flexible way to put pre-tax dollars into a healthcare savings account, essentially, that can be used for premiums and can be used for wellness and other things in general. But excited to hear from you guys, because I do think when you're looking at direct primary care as an alternative, or any other healthcare as an alternative, that the supplement, wellness is a story. Wellness is weaving a fabric of the right types of insurance and the right types of personal wellness support that you might get from outside of insurance providers to make it all work. So thank you.
Absolutely. So we are familiar with the direct primary care, and that has been, when I first heard about it, I literally pitched myself going, they really came up with something that I've been doing health insurance since 20 years now. So I watched it when the premiums were $1.50 and we had just a copay, and I watched it go through the Affordable Care Act. I watched it go through everything and get to this point, and I'm providing small employers these quotes that are just astronomical, and I'm sliding across the table going, I'm just reporting to you.
Right.
So I was never a person just to say, here it is, take it or leave it. Finding solutions, Avid Risk Solutions. We're here to find solutions for you. So the direct primary care was one of those solutions, and Advocate MD, I received a tour over there and got to know behind the scenes. So just to hear your story was just phenomenal. And the biggest thing is knowing these resources and being educated and making sure that you are knowing how to get around. And this is phenomenal because it's a great correlation to an individual coverage health reimbursement account for employers. Being able to get that primary care and then also match it with maybe a really high deductible health plan to have, just in case if something major were to happen. And then also the supplemental. So it all really bridges together. And for low cost compared to that premium amount for $500 deductible plan. So with the individual coverage HRAs, this was one of those opportunities for employers to offer coverage and a subsidy or an amount to their employers or employees without, in the government's eyes, doing something illegal. So when the Affordable Care Act came into play, previous employers had said, go get individual plans, they're so cheap, just compensate, write them a check, you're fine. Now it's legal. Now you can't do that anymore. Now you can't have a line item that says health insurance on it, or you get penalized really heavily. So these allow you to do it the right way and really track where those dollars are being allocated. So it goes outside of even just doing the healthcare reimbursement for health premiums. You can do it and allocate dollars into a benefit type bank. So you can say for wellness, for mental health, for clothes. I mean, if there's certain uniform that you have to wear, or, going into the professional world, it was expensive. You had to wear heels, you had to wear the pencil skirt. I wore my same outfits over and over, but employers are able to get those startup employees a dollar amount into their funds. And truly, those employees it's not just cash, it's something that they can see, use on a benefit card and attach to their employer. I have this information that goes into more details. With the individual health reimbursement accounts, the employer truly does have the reins of how they want to control the contribution. Do they want to class it out? Do they want to do a certain dollar amount for part-time employees and full-time employees? So they're the ones controlling it. Government has nothing to do with it. Carriers have nothing to do with it. They are the ones that are taking the control of it. So that's it for the health. Does anybody have any specific questions on that at all on the health reimbursement accounts? I mean, this is one of the best tools that I was able to locate through our resources that really takes you through those questions and the pros, the cons into offering the individual health reimbursement accounts versus a traditional group health plan.
Yeah, well, one thing that kind of triggered with me with what you're saying is, this is your oil change, this is your tire change, this is what you're going in for. The fact that such high premiums are being paid for those things is the majority of what you see. And when you talked about, for the catastrophic thing, you fall out of your tree stand and break your leg, and now you need some type of surgery, the cancer diagnosis, the heart, all those do need something. There is a fit there, and you think about it, if you put in a high deductible health plan, you're still paying a pretty significant amount of premium. Your high deductible health plan is probably $7,000, $8,000 out of pocket, so there's still a pretty significant cost to you if something major were to happen. And that's where I focus on supplemental benefits, and that's where these, for a very low dollar premium amount, can really help offset those very large claims. You can put in a $20,000 critical illness plan that's going to help offset maybe that max out of pocket for very minimal dollars. You can put in an accident plan that's going to pay you $7,000, $8,000 for that broken leg when you fell out of the tree stand. Again, the hopes is you're not going to use those, and they don't cost. We're not talking $1,400, $800 a month. We're talking like 15 to 30. So with something like that, whether it's with the direct care primary, whether it's with a state-funded plan and you choose a high deductible health plan or sorry, an ACA, or whether it's your group plan. And one thing we feature we have a lot of restaurants and a lot of franchises, everything from mom and pop 5-person restaurants to 5,000 employee franchises across the country. And the one thing that our enrollment team puts all across the lot is, man, I really want to get the health insurance, but even with employer contribution, we still can't afford it. And that's the same throughout the whole industry, it seems of it. So we do see a lot of people putting in supplemental benefits just because, 72% of Americans live paycheck to paycheck. A lot of the restaurant industry falls in that. So with that, if you're living paycheck to paycheck and you get injured, your bills go up, you got deductibles, co-pays, all those things. You're not working because you broke your leg, you're out 8 weeks. All of a sudden, now you're not making income. Now you've got this huge gap that needs to be filled financially. And that's where some of those supplemental things for a low cost can help really fill that gap financially. And it's not tied to whatever health plan you're on or anything like that. You can choose what you need to put in place.
What do you mean by supplemental benefits? Specifics.
Oh, so
Yeah, what
like
are
what?
supplemental benefits?
So supplemental benefits. I'm like,
I've never heard of them.
So some of them is you're talking about accident insurance. Okay, you're talking about critical illness. You're talking about life insurance. You're talking about short-term disability. Again, all the things, and that's with insurance in general, things you don't want to use, but all the things that you can still put in place to financially protect yourself when the bad does happen. I look at that as more as that's the car insurance for when I got in my wreck.
It's me next. Okay, so I, as someone who focuses more on the individual side of things, and also who worked in the service industry for almost 20 years myself, understand that you're kind of, like Dr. Wendy said, you're in this weird gap where, maybe benefits aren't offered to you, or maybe it just makes more sense for your income to get an individual policy. And a lot of folks can qualify for discounts on their premiums going through the ACA or getting an individual plan. And then you can also use that plan in concurrence with going to see Dr. Wendy, and of course with your supplemental benefits as well, which is great. One thing too that some people, and this could be talked about in further detail, but HSAs are really powerful as well. Health reimbursement accounts, or health savings accounts, sorry. And you can use those funds at Dr. Wendy's office as well. So another savings tool there. But yeah, I think individual insurance, depending on everybody's situation, can be a lot more cost effective. And also typically we can sign you up for a catastrophic plan as opposed to a plan that would have all those co-pays and things, because obviously you can go see Dr. Wendy and then use that for anything catastrophic that would happen. That would be the car accident of the scenario. So yeah, and all that gets really confusing. It's very confusing, but I'm happy to help assist people because health insurance is for profit, and yeah, it's confusing. So that's what I'll say about that.
So as an employer, I wouldn't necessarily hire you or pay you, but I would somehow pay the health savings account and then they could buy through.
Right. Well, okay. So this is where. So I also, okay, so you could get a group policy for health insurance through me or them. What my piece is focusing on individual would be more just for your individual employees to go and get their own insurance policies on the side to help with the catastrophic coverage. So as the employer, you wouldn't necessarily be involved, if you will. That would be more on the individual side of things. But so yeah, that would pair up. So individual health plans with the individual health reimbursement accounts. From an employer side and the HSA, I mean, honestly, we can sit here and talk all day long, and you guys would be asleep within about 20 minutes. Yeah. So there's so many moving parts
a big focus aside from just the group health plan and the employer. So is looking at the high deductible health plans, funding it through an individual HRA as the employer. So using that to fund those pre-tax dollars and allocating those dollars if it's to the premium, if it's to the deductibles, if it's to wellness. The universal benefit account, that's what I was looking at. Task is one of our partners that is really, they're above and beyond just looking at that HRA, FSA. I'm using a lot of terms that you guys are probably going, really? But it's all these fundings of just specific to medical, where now it's really taking it outside that box. So for the small employers, for the, you know what, we love our employees. We know they're going to qualify for subsidy. We know what they make. We're running their payroll. We don't want to hurt them, because once you start getting a group plan, they might disqualify for that subsidy.
Thank you, yeah.
Yep. And then they are subject to penalties. And if they don't know about that, the government at the end of the year is saying, hey, I want my money back. You just took it. You had a health plan and they were never educated on it. So this is a safer way to really protect your employees from that.
So like as an employer, I would contact you.
We all would.
Yeah,
you all know what's
yeah. And I would say, hey, I have this amount of money, I have this employee, this is what I want to give them, and you guys could help figure out how that works.
Absolutely, yes. So it's, you know, finding that identified budget amount is what it comes down to as an employer. You know, we want to work within your budget. We are paid by the insurance company. We're not, you know, charging you a fee. So we're trying to work within, if you say I can allocate $200 a month per employee, we're going to work with that budget, and we're going to try to find supplemental, individual, really tie them in together to help you out.
To give an example, we had a group that basically was a new HR, their first time into benefits. Everybody was new, and big thing, they kept asking us questions. We answered the question of what coverages were. The big thing was, what's comfortable for you? You're the one that has to see this bill every month, in good times and in bad. So let's build it so it's comfortable for you, and then as you grow, we can build it from there. But let's really look at what works for you, and then we can go to all the acronyms, figure out which acronym is going to fit your dollar amount the best.
And you also want to offer something great for your employees as well. Employee retention is huge.
Right.
That's why you offer the benefits.
So that's
But
when
you also want to be
guys
able to
come in.
afford it.
You say, hey, I can get you the best. They're piecing all of this together. For
Not
you.
the traditional, I'll just quote your insurance.
Yes.
You can find out there.
Yeah.
But you just can't afford that anymore.
Right.
No, absolutely
It's
not.
not feasible.
And, I mean, employers have such a hard job right now because that's what everybody is expecting.
Yeah.
Wanting and expecting, and it's not an easy balance.
It's an employee market right now.
And going against some of the large giants, I mean, some of the state plans, and you know, they're great, but it's not in the budget of a first-time business owner. It really isn't. Yeah, and we've noticed that, and unfortunately, the healthcare system hasn't. So we have to work with what we're given, and the direct primary care was a great foundation of saying, hey, this is broken, we need to fix it. Unfortunately, there's so many band-aids with the health insurance, but it's using the legal ways of doing it where we can find those solutions.
Problem solvers.
And because direct primary care is completely out of the system, you don't have to use an ICHRA to help cover it. You could just fund that completely separately. But if you want to give your employees the flexibility to say, hey, I get my health insurance in the marketplace, or I choose, I cobble together high deductible and direct primary care and all these other things, the ICHRA allows you to fund something that then your employees can do whatever constellation of things they're doing, and you can support them in doing what's best for their wellness, which is why I think it's such a cool vehicle.
Any other things to add? Any other questions that we have? So quick question on practice. So what, just roughly, what are the limits? Like how many patients do you need to make a practice, and then what's the total population that you can serve?
That is an excellent question. So as a former employed primary care family practice doc in one of the big systems, I was a 0.6 FTE, so 60% time. My patient panel was 2,500 patients. 2,500 patients. Well, and this is why I kept hearing, hey doc, I can't get an appointment with you for 3 months. I got to see whoever's available. I'm being told to go to the urgent care. I look at my schedule and have panic attacks every day because I already have 25 people on my schedule, and there's people calling in who want to see me. And so
trying to squeeze them in.
And I'm like, yeah. And so then I'm up pajama charting all night because I go home and put the kids to bed and then stay up all night charting. And so, yeah, it was not sustainable. So a typical family practice for a full-time position is about 2,500 to 2,800. So I was carrying essentially a full-time load at 60% time. For a DPC doc, a direct primary care doc, everybody's still like, what? I'm like, no, that's way better. Is somewhere between 500 to 800. So depending on, what you're working, where you're doing, etc. I would be at the lower end of that. I'm looking at closing my practice at about 400 to 500 people because I do so many other things outside of the clinic. So like I said, I'm current president of the Wisconsin Medical Society until this Saturday. Then I'm turning it over. But yeah, heavily involved with the Medical Society, believe in advocacy for patients and physicians. I am co-chair for the Wisconsin affiliate of Reach Out and Read. Reach Out and Read is a early pediatric literacy program based in primary care clinics where we give out books that are age appropriate, language appropriate to kids at their well child checks, and talk to patients and their parents about the importance of reading at home and kind of talk about early relational health and some of the scaffolding and language development with infants and kiddos. So I do that as well. And then I also sit on the Department of Health Services Immunization Council. So I do things outside of that as well as, I'm a mom, a wife, and other things as well. So I'm going to close probably at about 400 to 500. That being said, the reason that I'm in the office that I'm in now is that I already decided that at some point in time I'd like to grow. And so I have the ability to add a position at the location I'm at. The other exciting thing that I'm working at is working with a mental health provider and a dental provider, and we're looking at some point, probably in a year or two, having our own facility where we have mental health, dental, and primary care all in one location that are all kind of these, direct primary care, sliding fee scales for mental health and dental, and some of those things. So there's growth there, and I think the other thing that's interesting is that more and more of us DPCs are popping up all over the place because more of us are abandoning the Titanic, which is impossible to turn, and getting into our little dinghies and rowing away as fast as we can. So
To use that analogy, because 111 years ago today, they worked the Titanic.
Whoa!
Or you didn't know that?
I did not.
Back out of there.
That's amazing. No, I did not on purpose use that, but thank you.
You mean you did?
Oh, I did. I totally did. All over that.
She's only been waiting 100
Well,
Yeah.
unless there's any other things we want to talk about, I think that's a really good length for the video, and I appreciate all of your input. It was like an incredibly informative one. I hope this gets out to you. Anything else before we close down? Katie, any comments online? Could you hear okay?
Yes, and I just wanted to say, and I know that you already said thank you, but thank you all for coming. I feel like this is just such an important conversation to have and to continually have given the need. So thank you so much.
No problem.
Thank you. Our
Thanks.
pleasure.
Yeah.
This was great.
Yeah.
Thanks for doing it.
I'll stop the
I don't think so. Yeah. I joined the